Okay. Today is Thursday, August 2nd, 2018. This is Hannah Crawford for the Global Polio Eradication Initiative History Project. I'm with Virginia Swezy at the U.S. Centers for Disease Control and Prevention in Atlanta, Georgia. Thanks for being here today.
I'm glad to be here.
So before we open, do I have your consent to conduct and record this interview?
Yes.
Okay, great. And so let's open. Would you introduce yourself by name and state your roles in polio eradication?
My name is Virginia Swezy. I'm currently the Deputy Director for the Global Immunization Division based in Atlanta, and I have been working in polio for about 20 years. I started off as a student intern when it wasn't a global immunization division, but back when it was just the polio branch. And I have been in the group for 2 decades, primarily on polio, and more recently, broader based across the division.
Great. So to pivot, in oral history, we begin at the beginning. So would you state where and when you were born and share a little about your early life?
I'd be happy to. You want to know the year that I was born?
If you're comfortable sharing it.
I embrace my age. So yes, I was born in April 1966 in Vientiane, Laos, and spent the first few years of my life outside of the U.S. And came to the U.S. As a young child, and like many Americans now, learning English as a second language in the early part of my life.
What was that like? What are your memories of learning English?
I think the two things that likely stand out for me in terms of learning English as a young child, I think the first is everyone around you knows something that you don't really know, so you're really eager to figure out how to engage in those conversations. And I recall being with my mom and my sister, and the three of us all learning English at the same time. So I think there was some comfort in having that small group of us trying to do that together.
Could you tell a few stories about your family members?
Sure. I very, very lucky to still have both my parents, and I'm very grateful for that. They're now elderly and living in the Northern Virginia, Washington, D.C. metropolitan area. I have an older sister and 2 nephews that are also in that area. I have 2 baby brothers now with their families, 1 brother in Colorado and 2 nieces, and then 1 younger brother in California with another niece. So lots of nieces and nephews scattered around the United States.
Big family.
Mm-hmm.
What are some of your memories about, I guess, influential experiences when you were little? What do you connect to who you became as an adult?
That's a really interesting question. I've actually thought about that before. I think when I was an early teen, I remember being really determined, and my aunt recently reminded me of this. She thought it was really surprising at the age of 13 that I already knew I wanted to join Peace Corps, and that always was interesting to her, and she reminded me of that story, and I had forgotten about that. And she asked me the same question, and I think that determination really came from being new to the U.S. as an early child, and always having that curiosity to look back outside beyond the country that you're living in and really look across the globe. So I think that coming into the U.S. from outside the country maintained an interest in terms of being interested in global. I also had my extended family that came from Laos when I was 10. They were actually refugees that were in a camp for about 9 months when I was 10. And I recall them all coming over and coming to the U.S. and settling. And I think that just having that experience of coming to the U.S., having extended family come as refugees has always been an incentive for me to look beyond our borders and to see what we can do to maybe make it a little bit better in some way, shape, form, or another. And I think that as a young child, you don't really know how to do that. So when I saw these Peace Corps commercials on television and I saw these young adults out in the world, I said, that's going to be me. That's what I want to do. So I think that was sort of a couple of the catalysts for moving in the direction of global health.
Could you describe a couple of the Peace Corps commercials you remember?
Well, I think those commercials are probably still very much on the television. I'm not sure they've actually changed over the decades, but you see that young, energetic, really optimistic youth who is in some interesting locale, whether that's Asia, Africa, or somewhere, and is smiling and working alongside the population that they're serving, and that just really, really appealed to me.
Cool. So let's talk about your early career, if it's okay, just moving forward in time. I know that you went to Emory for an MPH.
Right.
But leading up to that, what was your trajectory into public health?
Well, I actually, before getting an MPH at Emory, I got an undergraduate in anthropology. So again, that was just an interest to learn more about the global environment that we live in, and that was a way to focus on trying to learn more about different populations. So really started off with a strong interest in anthropology, went into Peace Corps, and then immediately after Peace Corps realized that on some level the anthropology degree was a bit academic. I couldn't really figure out how to apply it in a way that I was going to be truly fulfilled. So during my Peace Corps experience, I had the opportunity to be engaged in a child survival project. And so by sheer chance, I was assigned to a child survival project which focused on immunizations, on ORS, which is combating childhood deaths by diarrhea, and then malaria. So that was really my first glimpse of public health in Peace Corps, and that really was, I think, the piece of information that I needed to apply that anthropology and really look at how to apply that more globally. And going back and getting an MPH seemed like the next step and the next natural thing to do.
I wanted to see if you could tell a few stories about being in Togo, which is where you went for Peace Corps. Could you tell the story of maybe your first day or leading up into your first day? Well,
the first day was I think I actually remember the plane ride from somewhere in Europe and this was a large group. I think we were 15 to 20 who traveled together. I remember going through the airport in New York, and I remember an entourage of people running by us. And it was an entourage of, again, a dozen or 15 people, all in the same outfits. And looking in the middle of the entourage, I realized it was Mother Teresa and her entourage just sort of whizzing by us as we're getting on this plane to go to Togo. And I thought, I think that's a good omen. So that was the beginning of the trip. And then connecting in Europe to go down to Togo, there were a couple of Togolese that were on the flight, and just being really excited, sitting next to a number of new friends from Togo on the flight and talking about the country that we were about to go to. So that was actually the first day, even before we landed in country. And remember the plane doors opening and just sort of the smell of the sea and the coast and the humidity and just being really super excited about landing in this new place. So it's always going to be a special place for me. So whenever I hear the word Togo, which isn't very often because it's a very tiny country and they're a very, very small population, but it's always something that evokes that excitement and that energy of those first 48 to 72 hours there.
And what were you there to do?
So the project that I was assigned to work on was a child survival project, and it had 3 components. So immunization was one component. There was malaria, and then there was ORS, which is really teaching moms in the community how to make an oral salt solution because of the problem of children dying from diarrhea. And so it was a very specific child survival project.
So, what did you learn about immunization?
Well, I think my first glimpse in immunization is it's not as straightforward as one would think it should be. On some level, you think a vaccine exists, it can protect your child, and therefore everyone's going to accept it. And I think the thing that I learned is it's not as simple and not as straightforward as vaccine good and everybody's going to accept it. But it really is much more complicated and much more connected with other influencing factors. So I think I realized that it was a very complicated landscape even in those early years.
And are there any particular stories that stand out in your memory that illustrate the challenges and the complexity?
Well, I think when I think back to the rolling out the immunization program at that community level, I think one facet of all of that was, I think, an eye-opener for me was trying to get the information down to the community level. The community level at that time, and remember this is 3 decades now, but it wasn't a time when there was widespread use of television or even radio, and certainly not internet or mobile phones as we do have now. So really the challenge of trying to reach mothers and families at the most remote areas when you didn't have easy access to those communities, and really trying to get community mobilizers, if you would, people in the community who could actually help bring those messages to the moms and community leaders. And I think that was something to me that was a huge challenge, is really getting messages to where it needed to go, and not just at that sort of entry point in the community, but really getting into the homes and reaching moms and families. So that was challenging. I was assigned to a Ministry of Health counterpart from the Capitol, but again, he was coming in as an external person, as I was, and we could have an entry point into the community, but it wasn't enough for the 2 of us just to come and talk to 1 or 2 people at the leadership level in the community. It really was much the need to really do outreach and get into the homes and talk to moms was a huge emphasis. And I think we just were not prepared for that when we initially started the project. And there was a lot of energy and effort that we needed to put into reaching moms in homes and really having that one-on-one direct contact.
So, what happened? Is there anything else you'd like to share about Peace Corps? Lessons learned from that time?
I almost sound like I feel like I'm going to be a little bit of a commercial for Peace Corps, but it really was such a game changer, I think, for someone like myself who was interested in global issues, trying to figure out an entry point in terms of having an impact globally, not really knowing as a young child or even an early adult how to do that. But I think the opportunity to go into Peace Corps and see something like a project that could be impactful really was a game changer. And I think really was the game changer in terms of the trajectory for the rest of my career here at CDC. So we could probably take this and put it on the video for the Peace Corps commercial.
It really worked for you. So let's go ahead and move forward in time. What happened after Peace Corps? How did you transition out, and what were you planning to do?
Well, I left Peace Corps. I went back to Washington, and I ended up working with Peace Corps headquarters, which was much more of a programmatic, sort of Washington, D.C. based perspective. So that was really my first entry point into working at the global level in terms of managing some of the Peace Corps portfolio. So I did that for a few years, and I think that was really very enlightening as well. And then I had an opportunity to have another overseas assignment, and I worked as a special projects assistant in the first U.S. Embassy in Turkmenistan. So again, a few years in Washington with Peace Corps, and then back out overseas to Turkmenistan, primarily looking at how the U.S. was going to support the new independent country of Turkmenistan, which had just separated from the Soviet Union. So that was an interesting time, an interesting project as well.
There are lessons learned from Turkmenistan that were relevant later.
Turkmenistan is such an unusual country, and it was such an unusual time. This was, again, back in the early 90s when all the newly independent states were emerging and standing up. So it was a really interesting time, I think, in our history, and a really interesting time, I think, globally and diplomatically, as a handful of countries really were overnight. All these new countries on the map that had been formerly part of a Soviet Union were now new countries. And so it was really a new frontier for, I think, the world at large, with so many new countries on the stage. And as new countries really trying to understand how to exist and how to interact and how to engage with the global partnership as well. So I think that was really an intriguing time. I'm not sure I've seen that repeated or that same scenario happen since that time. But an interesting journey nonetheless, to as we think back to the last 25 years of those new countries as they were 25 years ago, to see where they are today. So really exciting, kind of like seeing somebody grow up, if you will, sort of that new country birth happening in the early 90s, and seeing all these mature countries now, and how independent they are, and the capacity that has grown over the course of many years. And but I don't know if there's a similar scenario that I could apply that to.
But do you feel like you developed competencies or skills during that time that were relevant later on when you were working in India or working in country?
Well, that's a really hard question. I'm not sure if I can. So I had worked in Kenya and India, which were such well-established, if you will, contexts, especially on the immunization front or portfolio. So maybe not so much in terms of sort of the professional aspects. Certainly, I think that those early years, even in Togo and Turkmenistan, I think they refine your social skills, perhaps, maybe not so much on the professional side, but the social skills in terms of approaching a new country, maybe not necessarily new for the country, but new for you, and what you would do approaching a new environment. And I think lessons learned and elements of that are when you go into a new environment or a new context, you go in with your eyes and ears and your heart open. You make no assumptions. You listen. You learn. You try to understand as much as you possibly can. And after taking that time to try and understand that local context, then slowly but surely applying your knowledge or your skills or your programmatic priorities in that local context. I think those are the things that possibly you learn over the course of a number of years and being in different countries. So I think that's a common element when you work in any new context.
So you were in DC working at Peace Corps headquarters,
Mm-hmm.
and then Turkmenistan. And then did you come back to Emory?
I did. When I was in Turkmenistan, working as an assistant to the ambassador, that focus really was to identify programmatic areas of that new country that needed or would benefit from some capacity building or cross-training. So, for example, if the Ministry of Agriculture was interested in trying to enhance capacity for our colleagues, we would try to identify a partner in the U.S. and send relevant colleagues from Turkmenistan to the U.S. on these exchange programs. So they might come for a month or 3 months or 6 months, depending. And that was really interesting, again, as a person coming in and trying to identify what the priorities were for the country, trying to match it up with some of the capacity that we had, and trying to enhance capacity in that new country. I think that over the course of those 3 years, my interest and my focus on health really did start to emerge, and probably because of that prior experience in Togo. But I continued to find myself really focused on and being interested in the health portfolio. And so I think while in Turkmenistan working on a number of these project areas, I decided that it was time to go back and get some additional training in public health and really just focus solely on public health moving forward. So yes, that's when I came back to Atlanta. That was 1996, and I had planned to come for 2 years to go to Emory, and I have not left since. So that has now been 22 years. So 2 years turned into 22 years.
I remember you saying that you had several important internship experiences as a student, the domestic STD program.
Right.
And then you were also at the Task Force for Child Survival and Development. Could you talk about those experiences?
Sure. So, I mean, the great benefit of being at Emory right next door to CDC and the task force is perhaps unbeknownst to some students, you have this amazing public health community here in Atlanta. And I have to confess that I was one of those people. I came solely focused on Emory and discovered that there was a whole other universe of public health here in addition to Emory. So while I was going through the 2-year program, there were a couple of opportunities that were advertised through the student network, and one of them early on was an internship with the CDC. So I applied and was pleased to be accepted, and was placed in the domestic STD, I think it was the domestic STD program at that time. I'm not sure it's still named that, and came over to CDC on my first assignment. And I think it was 3. It was a summer internship, so it was 3 months. During that time, met a colleague who also happened to be a returned Peace Corps volunteer from Africa. And in my 3 months of working on domestic issues, I think he recognized that a more appropriate placement for someone like me was going to be working in some global program at CDC. So it was actually this person who said, "Oh, I think you should meet the polio eradicators. They're upstairs." And so I was not aware that there was a polio eradication program. And through this gentleman, I went upstairs and was introduced to Bob Keegan, who was at the time the deputy for the polio project.
What was it like to meet Bob Keegan? What do you remember?
I think anyone who ever meets Bob doesn't forget meeting Bob. He's somebody that leaves a lasting impression. And I say that in the most endearing and affectionate way. I think in the immunization world, if you say Bob's name, it always evokes, I think, a great deal of affection and admiration. So, yes, I remember the first interaction with Bob very well. And he was very energetic, vivacious, and very direct. And I think I recall being a little stunned by that in my initial interaction with him. And over time, of course, really coming to greatly admire energy and that directness, and really, trying very hard to follow in his footsteps over the years. And I think there was a saying at one point among a number of us, when we got stuck on a problem, we would say, okay, what would Bob do? So it became this coined phrase of, when we got stuck, okay, let's sit down and let's think of what would Bob do in this case. So a great deal of admiration and affection, and certainly remember those first few moments of meeting Bob.
And what was the occasion for meeting him? Was it the introduction because you were interested in working in a global program, or?
Yes. Again, I hadn't even quite connected the dots of really trying to. At that point, I wasn't fully aware of what the polio program was about, and so the colleague in the domestic STD program was convinced that was the place for me, and so brought me upstairs and delivered me to Bob's office and said, "You two need to talk," and that was the beginning of a friendship that spanned a couple of decades, absolutely, and certainly through my time in India, Bob continued to be a great resource for me, an ally, and had come out to India a couple of times and helped me on a couple of projects as well. So I did not realize at the time that there was any interest from polio in my candidacy. So it was an introduction talk, and I think that in talking with Bob about my history and my background and where I had worked, I think he was interested in exploring whether or not there would be possibilities. So that wasn't actually seeking anything. It was an introduction. And then later on, there was an opportunity that came up, and we took that opportunity, and I moved over to Polio as a student intern as well.
Mm-hmm. And when were you at the task force?
So while I was a student intern first in the domestic program, and then I moved over as a student in the polio branch. So that was while I was in school. And when I graduated, the internship option was no longer available, just based on the internships, which were for students. And so I was, upon graduating, I was offered a position, or I applied for a position at the Task Force for Global Health, and joined them shortly after graduation and worked there for about a year. And again, it was a domestic-focused project. And I was very engaged in that. And one day, and after about a year, got a call back from Bob and said, "Hey, I've got a position. We're trying to start up this program. It's called STOP. It would be great. We'd love to get some help. Are you interested?" And I said, "Yes, absolutely." And so that was the beginning of STOP. And so that was 1999 at the time. Mm-hmm.
The internship in the polio eradication branch was really important. Say you worked with Roland Sutter. You worked directly with him. Is that correct?
That's right.
Could you just talk about the internship?
Yes. So as a student intern, Bob had asked me to come in and work with Roland Sutter, who you know. And Roland at the time was in charge of, I think there weren't specifically branches at the time because it was not a full division, but there were programmatic areas, and Roland was the polio program director, if you will. So this was a time when I think there was a surge of CDC support in the Global Polio Eradication Initiative. It was still a very small team in Atlanta. So it really was sort of the bare bone minimum staffing. And I want to say that at one point, I recall we used to, and Steve Kochi was the director. I recall having all staff meetings in Steve's office, and there were a couple of couches, and I think we actually all fit in there. But Roland was the polio lead, if you will, and so I came in to support Roland in his leadership capacity in polio eradication. for a few months. So really got to know Roland very well, and I really, to this day, again, have a great admiration and grateful for a friendship that I have with him as well.
What was his office like, and what was he like? What do you remember?
Roland was and continues to be absolutely one of the most brilliant scientists that you could ever hope to work with. He is, I think, the world's expert on the polio virus. Over the decades that I've known him, completely unwavering in his focus, unwavering in his calm approach, absolutely collaborative and constructive. So he really does embody all those elements that you hope to have in any colleague that you work with, let alone you aspire to have on a personal level. So he really is the epitome of what you want to be as a professional, which is calm, focused, expert, collaborative, and just really terrific to work with. So he was at that time in the late 90s, and he is absolutely unchanged to this day, and all of those characteristics. So I really, really appreciate working with Roland. I think the surprising thing about Roland is in his very, very focused and calm demeanor. His office is the complete opposite of him. It is, have you seen Roland's office?
No.
Okay. Roland's office is piles and piles and piles of lots of journals and articles and lots of really important documents. And I think I'm always amazed if you ask him for a specific article or write-up on something and you tell him the title, it could be from 12 years ago on a given week, and he will be able to find it in his office. So I don't know how he does that, but that's a trait that's also truly admirable, and I've never been able to replicate that. So, and I often see him now in Geneva, and I will often comment on the state of his office, even 20 years after I tried to help him straighten it up.
Do you have any stories about Roland Sutter? Or first meeting him, memories, that kind of thing?
Well, when I first met Roland, I recall that he was very very quiet, and he doesn't immediately show any emotion. So walking into his room with a very sort of quiet, demure, sort of intense look about him, and in his presence that he's a brilliant scientist. So being really intimidated and not knowing if this was going to be somebody that you could work with just because you weren't sure what he was thinking. But he really is absolutely not what your first impression would say. He's absolutely full of warmth and very expressive. So, but my first reaction was, oh my, he's very intense. I'm not sure we're going to get along, but that's absolutely not what ended up happening. He's absolutely a delight. So I hope this isn't going to get me in too much trouble with him.
So you were there to support his leadership role, you said. Mm-hmm. So what kinds of work were you doing with him?
Well, as a student intern, not very much, because I really didn't have the subject matter expertise. So it really was sort of the day-to-day task of helping organize for meetings, or possibly taking some minutes, or task in terms of trying to help organize some of the materials that he had. So it was really, very not very sort of, I would say, high end. It was really sort of student intern kinds of task and organizational kinds of things.
Were you learning about polio?
Well, you always have the opportunity to learn about polio, regardless of what your role is, I think, in the division. There are always, at the time, there were many, many opportunities. There were constant meetings taking place. I think at that time, if I recall correctly, there were still 25 countries that were endemic. So it was a constant discussion and a constant effort. We were a much smaller team. We were only focused on polio. So that very small team in Atlanta, focused on polio, covering 25 endemic countries, was a handful. And so there were lots of discussions and interactions among the team members to talk about what could be done in these last, well, we thought at the time, last few countries. At the time, it was also a very intense period because we were still optimistic and trying to beat the clock of polio eradication by 2000. So it was a pretty intense period of time those last couple of years in the 90s to eradicate polio.
There were actual clocks, the countdown clocks. Were any of those around you? What kinds of objects were around you at that
There
time?
were the countdown clocks, and I remember seeing the countdown clocks in the offices and on the shelves. And I remember walking into offices in that year, and the first thing you would glance at was the clock. And there would be numbers on it, and it would be the hours, minutes, seconds countdown. And so, in addition to it just being an intense period of time, the clocks were a visual reminder of the clock is ticking. And so that was, I remember being very aware of the clocks when you walked into an office and you saw those numbers coming down rapidly. So it kind of created this additional stressor, if you will. But it was also a great time. I think that the times of intensity, when you have a lot of pressure and you're trying to do a lot and it's a small team, I think is also a time of great camaraderie as well. And so there was a great deal of camaraderie. But of course, it was also, the legends that were leading us. It was Steve and it was Bob and it was Roland. And so with those kinds of legends and their kind of esprit de corps, you couldn't help but have a great deal of camaraderie and determination to really get this done.
Could you tell some stories about Steve Kochi?
Steve Kochi, I can't say enough about. There have been, I think over the years, Steve has demonstrated just this unwavering commitment to polio eradication. And if I were to stop and think of anyone in the world now who was more committed to polio eradication, I probably couldn't think of anyone that would top Steve. Maybe it's Roland and Steve toe to toe. But I see them and I see Steve as really the person who wants polio eradication to happen more than anyone and is so determined and has spent a great deal of his career focused on this. So just a fierce determination, but a completely and totally kind and gentle person. So Steve was and is the kind of leader that I think it's easy to follow and you want to support him because he really has been such a tremendous leader for all of us over the last couple of decades. So I would love to see polio eradicated in the next few years. If not for the world, at least for Steve Kochi. But yeah, just somebody who's so committed and really looking forward to that day when we can all celebrate with him, because I think of him as sort of the initiator at CDC, if you will.
So the team, the trifecta, so you mentioned Roland Sutter, Steve Kochi, Bob Keegan, and being in meetings with them, do you remember some of the conversations? What were they talking about?
Well, I think they were often talking about, and mind you, the three polio eradicators, Bob, Steve, and Roland. They didn't always see eye to eye, and so what I think I admired about that is everyone had a very strong opinion. Everyone had an opinion based on some knowledge. and everyone was willing to stand up for what they believed in. They were willing to disagree with one another, and they were all super passionate about achieving the same goal. So always looking in the same direction, always committed to the same goal, not always agreeing, and sometimes just agreeing to disagree and just continuing to move on. So the conversations, I think, oftentimes would center around how to enhance the partnership, for example, if there were an implementing partner in the field or at a headquarter level that perhaps was not working to full capacity or for some reason wasn't delivering on its program in a way that it was felt was needed, there would be a discussion about how to somehow change the direction of that or put that back on track. Certainly there would be conversations about resource allocation, if there were human resources or financial resources from CDC allocated in one area, did we need to think about shifting some of the priorities to some of the other areas? There were a number of conversations about staffing and how to apply the right skills and the right numbers to help some of the countries. So I think those were sort of the general conversations that would take place, but always in a collective, spirited sort of way to really try to make things work to the best of its capacity.
So in 1999, I know that you got a call to move over to the STOP program.
Right.
But what happened between Polio Eradication branch and STOP? Did you make the transition directly from working with Bob, Steve, and Roland into STOP? The STOP program?
No, I was initially a student intern, but then when I graduated, I left.
Okay.
So I was gone for about, actually over a year. So I was gone for over a year and had gone over to the task force, and then came back in a full-time capacity just to support and work with the STOP team. And that was 1999. Right.
Thank you.
Yeah.
Okay, yeah, I got a bit thrown. Okay. So maybe it makes sense to go ahead and talk about STOP. Would you like to talk? Are there memories and lessons that you'd like to mention from your time at the task force?
Well, because it was so domestic focused, maybe we can continue and talk a bit more about the polio aspects,
great.
right?
Yeah. So could you tell the story of coming to work for STOP?
So I understood the basic concept of STOP, which was to enhance human resource capacity in the few, it was not so few at the time, but we were saying it was just a few countries left. So out of the nearly 200, we were looking at just 25. So it really was to kind of sort of get us over that additional challenge in some of these last few countries. And the way we considered to do that was to really look at human resource capacity. Can we infuse the last few countries with additional hands to really look at surveillance and immunization coverage? So that really was and I thought that was terribly exciting. That yes, let's get in and let's figure out how to support these remaining countries, and let's get all hands on deck and as many people as we can out there to really work side by side with ministries and really reach these last remaining corners. So I was very pleased. I actually attended STOP 1 training and met that first cohort of, I think it was about 25, and it was at the time all EIS officers getting trained to be deployed to the field for 3 months. So, no, it was a really, really exciting, I think, new, innovative opportunity to look at how to enhance and support ministries across the world in these remaining countries.
What was your training like? What was stop one like?
Stop one was 5 days, and it was a pilot training. It was the first ever training, and it was solely focused on polio. And it was, I think, bifurcated in two primary areas. I think the first area was really trying to reinforce AFP surveillance. So I recall lots of energy and time spent on stool specimen collection and how to really enhance AFP surveillance in the countries. And the other one, the other component that we spent quite a bit of time on was really trying to make sure that the vaccine was reached every child in the country. So really focusing to me on the two areas of AFP surveillance and making sure that vaccine reached the kids. So, and over the course of 5 days with a number of hands-on exercises.
Could you describe some of the exercises?
Well, I think I recall some role play. So if you're going to take a stool sample, that's a bit of an awkward conversation to walk into somebody's house and say, we're here to collect stool. So really just working with the EIS officers to say that let's pretend that this is a house and this is a mom of the kid. Now you're going to explain to her why you need stool samples from her child. So I think some of the role plays in terms of making sure that you knew how to approach a household and ensure that that was happening. And then in terms of some of the vaccination role plays, I think, again, recalling what some of the messages would be if you come up to a house and you're talking with the family, that you're explaining that I'm here because we're trying to eradicate disease. So it really was an opportunity to provide some role play to officers that may not necessarily have even had international exposure before. I think for some, this was their first international assignment and going into some of these really complex settings and also complex interactions where you're actually working with and talking with family members and households. As a first-time experience, we can't assume that that's going to be intuitive or really easy, but it's going to be something that is going to need to be a little practiced, if you will.
So what would you train people, what were people trained to say? How do you explain that you're there to collect stool?
Well, I think that, the sort of the basic practices that one would hope that when you're meeting somebody new is you enter a household, you introduce yourself, you explain who you are, you explain why you're there, you explain why it's important that this task be performed, that you're really trying to eradicate disease. And the only way to do that is to make sure that we know where it's circulating. And the way we find how it's circulating is we have to do some laboratory testing. So really just walking through and making sure that officers knew how to appropriately approach a household and really just start having a conversation with the family member. And I think that that's not always intuitive. I think, and especially in cross-cultural settings, it's sometimes, it could appear to be a bit overwhelming or you're not quite sure. And with the language barriers, that's also a huge issue. I think just reinforcing that if you're working through an interpreter, if you're working through a counterpart, you really have to make sure that you continue to look at the person that you're speaking to and not the person interpreting. You have to make sure that you give a few phrases at a time so that the interpreter doesn't lose track of what you're trying to say. So just sort of some basic principles of interacting in a cross-cultural setting where the language may not be the same, and just sort of universal principles of what works well when you come into somebody's home and you need to ask them for something that might be completely bizarre or unusual. And I think also explaining to officers that not to make the assumption that even though we as scientists or CDC colleagues know that vaccine is good, everybody's going to accept it if you come, but really talking a little bit about some of these cultural nuances or sometimes religious issues or other factors that may actually change that perspective. And so not to be surprised by it, but there would be pockets of resistance, and there would be families that refuse. And they have very legitimate and compelling reasons not to want the vaccination, even if you don't understand that. They have reasons. Really hearing that, understanding it, and trying to convey why you feel so important, why it's so important for their child to be vaccinated. So really just trying to, I think, bridge that understanding of where that person was coming from, because we can't assume that everybody is of like-minded or has the same information or belief system or comfort level with what it is that you're trying to provide. So I think some of these role plays were, I think, quite useful in just trying to make sure that this is not going to be as straightforward and as easy and as uncomplicated as you might visualize it to be. There will be many different scenarios and many different factors that influence decisions that we may not understand from our everyday life.
Do you remember any particularly challenging role plays?
No, I think the one thing that I would say over the years of seeing many STOP consultants come through is it's very rare to have somebody apply for STOP who isn't already, I think, really enthusiastic and eager to learn and understand and see how they can somehow contribute something to the program. So I think by definition, somebody who applies for STOP is somebody who is already interested in getting out to some of the most difficult places in the world and really just putting themselves out there. So maybe on some level, some risk takers, maybe a little more open-minded than sort of an average person. But I think that we've been really lucky, because I think that in order to actually take those steps and apply for STOP, you have to have some willingness to be in a situation that's maybe uncomfortable or unique or new, and to want to make something of that. So I think if it had been a program where it wasn't voluntary and you were sort of, it was mandatory, it would have been much different. But I think that the STOP cohort, and by definition, I think STOP members or STOP candidates are interested and eager for something unique and constructive and in difficult places, because I think you sign up for it. So
you went through, is there anything else you think it's important to record about being part of STOP 1 training?
I think you've got it.
Okay, great.
Yeah.
Great. So what happened next? You finished STOP 1, and then did you enter in as coordinator? You worked with Linda Quick?
I did, yes.
Okay.
I worked with Linda Quick. She was actually the coordinator at the time. And so these were the early years when it was a new project, new program. And it was I think I mentioned it was a very intense period of time. So really trying to take this new, this program and really try to apply it and in the most difficult places where we felt like they needed the most help or support. So it was really, it was uncharted waters, if you will. We hadn't done this before. We hadn't sent large batches of people out in the polio project before. So I think it was really just trial and error. Let's try this. Let's look at our training. Did we effectively hit all the activities, and did we appropriately provided training for that? Is there something that we could be doing differently? So I think with each stop training, we tried to reflect on, okay, how was the last one? From those who came back from the field, are there pieces of information that we could use to try and improve the training? Are we missing the mark on anything? Are we appropriately applying resources to the countries that need the most assistance, or should we be focusing on other countries? I think that when you look at the numbers of stop, if you have 25 and you have 25 countries, you couldn't possibly hit all the countries. Putting one person in every country may not have been the best way to allocate resources. So really just trying to see what the perfect balance was in terms of numbers of stop and the kind of training, and were they really getting to the root of the problem. So I think over that first year, especially cohorts 1, 2, and 3, it really was just trying to understand and invent that wheel as we were rolling down the road, if you will, and trying to understand how can we make this much more impactful for the countries that need it.
What were some of the changes that you made?
I think in the first cohort, I think some of the materials were, I remember actually, I don't think they make these anymore, the transparency papers. So I remember the first training, there were a couple of presentations where we had taken sort of that dry erase markers and actually made some of the slides and put them on the projectors, which I don't think are around anymore either. I haven't seen them in a while. So we fortunately I no longer use the transparency papers. We don't use the dry erase markers as we're actually presenting. But I do remember in the first cohort, we actually did have transparencies and were making drawings as the training was taking place. By the second one, I think we had started to make the transparencies ahead of the training. So we were actually developing them when the training was taking place. And I think that by the third training, we actually moved over to PowerPoint. So the transparencies eventually evaporated. So it was some of the tweaks like that. We also had, I think in the first cohort, had some images, pictures that were provided to the officers, and they could take it to the field, because if you're talking with community members and families, having some visuals sometimes, if you're trying to explain surveillance, it was felt like sometimes you could use some kind of a visual depiction. They weren't quite flip charts then, but we were trying to put together some materials that the officers could take when they were trying to explain things to the community. And again, I think over the course of 2 and 3 cohorts, we then laminated them at some point, and they weren't just pieces of paper. And then eventually they were actual flip charts that we outsourced and were actually professionally done. I've since seen a number of those materials, and I'm very pleased to say that they have vastly improved over the years in terms of how much more accurate they are, and how much more visually pleasing they are, and how much has changed. And I think that all those materials that are used at the community level have changed because of all the feedback that comes back after those STOP team members go to the field and they provide feedback. So it really has been an evolution of materials and sort of messaging that I think has been the result of feedback from lots of people over the years who have actually used the materials in the field.
What would you say some of the lessons learned have been for you from having worked for STOP or in STOP?
The lessons learned. In terms of STOP and polio in general, I think one of the greatest lessons over the years is no one organization or institution can go at it alone. It really, to me, I think the greatest lesson from STOP and polio is the amazing things that can happen in a partnership, and that collaboration of committed partners coming around to rally behind one cause is really the ingredient to success. And that has That has been so critical over the years because every partner brings its respective strength, but no one partner has all of the strengths. And so it's a bit like everybody putting their strength into the collective needs and really moving the needle in terms of polio eradication. And so the same can be said of STOP. We could not have, I think, deployed STOP and been as impactful if we had not had that collective partnership. We absolutely needed the implementers on the ground, and that's the host country ministry colleagues. Certainly WHO colleagues at the at global and country level, and UNICEF. And of course, you have to count STOP participants in that partnership as well. So the thousands of people who have come through STOP are, to me, part of that global partnership. We could not have done it alone with CDC staff. We could not have met the numbers that have gone out to the field. We could not have had access to some of the countries that stoppers have gone to. And so really, it's, to me, just the epitome of what a partnership should and can do if they really are collective and all working around the table towards a common goal. So I think that's been really one of the largest lessons looking back. And I think that as I look at some of the other immunization portfolios and projects now, I hope and I see some attempt at really trying to enhance that partnership for something similar is launched. And so where I see sometimes we may not be as impactful is also where I see sometimes the partnership is not as developed, or perhaps not as nurtured, or perhaps not as mature. So I think that should be a lesson for other global initiatives, immunization or otherwise, is that you really need a collective partnership that rallies around the same cause.
In our pre-interview, I also remember you saying that it's very important to build a team and build trust. But before, perhaps we could return, because I want to make sure we get into India. So in 2007, I think you left STOP.
That's right.
Okay. And then I know you worked in Kenya, you worked in the Republic of Georgia. Is that right?
That's right.
Could you kind of move us from that period of time into arriving in India?
So, yes, so the STOP, first year of STOP, certainly lots of changes, innovation, really focusing on how to fine-tune the machine. So I stayed in STOP for about 7 years. And I think over the course of those 7 years, again, even beyond that first year, it was, and I think this is true even of today, there's a continuous evolution and refinement because it's a changing landscape. And so I think STOP has been remarkable in terms of being responsive to the changing needs at the country level. And so even now I see this ongoing discussion with STOP to continue to try and change with the changing needs and the changing landscape at the country level. So certainly over the course of those 7 years, lots of changes. Our materials, our case studies, our recruitment, our business processes, a number of things continue to evolve and become more refined. We also expanded in those 7 years. So whereas in the early year or so of STOP, we focused solely on AFP surveillance and polio immunization days. Over the course of the years, we also learned that it really is a window of opportunity when you are talking about AFP surveillance or you're looking at NIDs for polio, to really look at some of the other vaccine preventable diseases, and also it's an opportunity to help try and reinforce routine immunization and reinforce measles as a priority. So over the course of years, we added a number of components to the STOP missions. And so we started looking at communication stop officers. We started launching the data management stop officers. There were also added to the technical components of AFP and polio. We started to look at how to ensure that there were other VPD surveillance mechanisms in place. So over the years, I think more and more things were added. And by the time I left in 2007, I think stop training had gone from 1 week to 3 weeks. And I think at last glimpse, it's still 3 weeks. But again, I sat through stop last January and was really so thrilled. I hadn't seen stop training in 11 years. So my last stop training was 2007, just sat in it this January. It's been 11 years. And to see how those materials had really become so much stronger over the years was really pretty exciting. So, but that being said, I left in 2007. I did go to Kenya for a couple of years. That was not polio related, that was HIV/AIDS related. So took a little bit of a break from the polio eradication world. The polio eradication world is a pretty intense one, and I think taking a break for a couple of years while my children were really very young was not such a bad thing. So I did take a break for a couple of years and moved to Kenya. And then one day again got a call from Bob Keegan saying, "What are you doing in Kenya?" And I think I said, "I'm working." He says, "We need you in India." And I said, "Okay, let me think about this." So I think a week or so after that, Hamid and I had a conversation. Hamid was the project manager in India at the time. Had a discussion with Hamid and agreed that I would meet with him. So I flew to India within a couple of months. We had a discussion, and I was super excited about the opportunity to work back in polio eradication, and then moved the family to India a few months later.
You mentioned the polio eradication world,
Mm-hmm.
and that it's intense. Could you talk about that a little bit? What do you mean?
Well, there's such a drive and there's such a determination. I don't consider polio eradicators to be your typical 9-to-5ers. I don't find them switching off at the end of the day. I kind of think of polio as a lifestyle, if you will. You are constantly thinking about it. You're living and breathing it. You're wondering what you can do to sort of get over that hump in this place or that place, or what you could be doing differently. If you're driving home and your mind starts to wander, it might be wandering to, okay, let's see, where's the last outbreak happening and who do we have there? So polio eradication is a lifestyle. It's not your conventional 9-to-5, and when you drive out of here, you think about something else. I see eradicators really as people who are living and breathing and thinking about this as a lifestyle, if you will. So I think that kind of intensity, that 24/7 intensity is, I think it is pretty intense. And I think that you sometimes have to be a little bit careful about how to make sure you draw the boundaries if there are other things that are happening in your life that you need to pay some attention to as well. So I had a newborn in 2007, so I felt like I wasn't able to do a 24/7 polio lifestyle at that time. So that was part of the reason for taking a little bit of a break as well.
So in the discussions with Hamid Jaffrey, what were those? Was the lifestyle part of the conversation at all?
It actually was part of the conversation, because by the time I was thinking about moving to India, my newborn was then 2. So I still had a bit of attention that I needed to place at home. But I was really, India for me was always such a huge draw. I had gone to India over the years. I had conducted some surveillance reviews. I had helped support some immunization campaigns, and I was really drawn to trying to make a longer-term commitment in India. So I was really, really tempted, and I really wanted to make it work. But I also wanted to show my cards. So I felt like I could only do that in person. So I did fly to India. I remember meeting Hamid. He wasn't in Delhi, so then I had to get on a plane and go to Lucknow and meet him. And I remember sitting with him saying, Hamid, I really want to do this, but I can only work until a certain time every day because I have to go home because of the children. Can you live with that? Is that okay? And he said, absolutely, we will make this work. And I said, okay, then I'll be back in a few months. And so, no, Hamid's always been incredibly supportive. And of course, also empathetic because he also had his family as well in India. So it was, it was not a difficult choice to make. Yeah.
So when you made the choice, what was the next step?
So the next step was moving to India, and I recall there was this urgency because my predecessor at the time was leaving mid-year, and I was really not able to get to India until, he was leaving early in the year, in January. I was not able to go to India until mid-year to finish off projects in Kenya, to get kids through school, and then move. So the next step was to get to India, and I recall being a little overwhelmed because there was no handover of my predecessor. So really landing and trying to sort out and figure out everything that was happening, but without the person handing it over, and that was a bit overwhelming. WHO was really very supportive in that they assigned a retired WHO staff to come to India between the time that my predecessor left and the time that I arrived. But she was not going to be in India when I arrived. She had gone back to Geneva. So I recall flying to Geneva to meet with her, to sit for a couple of hours so that she could brief me on the job that I was to do. And in hindsight, that was so appreciated, but it really felt like it should have been a 3-month handover and not a 3-hour handover. But so the first year was pretty tough of trying to understand all the different components. But really what made it work was having great leadership in Hamid and really having a great team in place who had been in place for a number of years. And so having that team already on the ground who I trusted very much, they really were the team that helped stand me up and keep me going over the course of those years that I was in that country office.
How did you go about getting up to speed when you started your position? You mentioned the 3 hours in Geneva, but what did you learn?
I learned it's a vastly complex project, that there were many, many, many different facets, and that you really wouldn't be able to fully appreciate it for a number of months. I think it probably took me about a year to really fully understand and appreciate the job in its entirety. But I had 3 team leads that worked with me, and I think the first task was really to develop a close working relationship with these 3 team leads, and having them really try to bring me into the fold and brief me as much as possible. So it really was spending quite a bit of time with the team leads. It was taking the opportunity to go out and engage with the field staff during these, what we called them was regional review meetings. We had 7 regions in the country, administrative regions, and in each of those regions we had a regional team lead and a deputy that oversaw the staff in that region. So mind you, the program was 1,200 staff. I didn't fully understand that when I had my briefing, but over the course of that year, I understood that it was 1,200 staff, 275 field offices. So really the way to understand and learn about the program is to really go to where the program staff are working and not in Delhi necessarily. So over the course of the first year, we tried to make a point to go to each of the regions, engage in these regional team meetings, and really meet the staff and have opportunities to have an interaction. So that was quite an intense first year, but I think a recipe that worked very well is having that regular exchange of these regional review meetings in each of the 7 regions. So I hope that answered the question. Yeah.
Yeah. A follow-up question to that is kind of the material and the information, the kinds of information you were absorbing in your first 6 months or so. What were the issues? Where was the program in its history?
So the way our program worked, Hamid as the project manager really was responsible for the overall project and certainly accountable for primarily all the technical issues. And so he relied on me to really try and manage more of the operational components of the program. So it was a good, I think it was a good division of labor. So on the financial side, the administrative side, and the HR side, those were the teams that I managed for the program. And so on the technical side, I wasn't as engaged in India on all the technical components. With Hamid as the lead, he had a deputy as well who was technical, and then of course all the different technical areas. So he had a very strong and very capable team of technical advisors in WHO. India, and that was not just polio, but it was routine immunizations, it was measles, it was the laboratory. So I mean, I think most of that focus went to him, whereas I was trying to maintain and manage more of the operational components. So really, I think trying to understand in the first 6 months how WHO worked as an organization. I had never been in WHO before. And so this was my first introduction to WHO and managing and operations of 1,200 staff and not having any prior experience with WHO. So all of the administrative policies, the HR policies, the financial aspects of it really were quite challenging. So it was really trying to learn about an institution and organization and how it worked so that you could best support and guide it. It was also the year that WHO globally migrated to this whole new online electronic system. So in addition to trying to learn all the policies and procedures and guidelines, we had to migrate and train all of our staff into this new online system. So there were quite a lot of growing pains from that. And again, India is the largest WHO country office presence in the world. And so trying to put this new system on this very large program was also especially challenging. So it was just a very interesting year. And I think that was the year as well that there were Commonwealth Games that came to India. And so we were in a government facility that was needed for the Commonwealth Games. And so we were removed from our offices for 3 months, and we had to find offices around Delhi and put different pieces of the office around Delhi. So there was that on top of it. So yeah, it actually, well, I told Hamid that I needed to switch off at the end of the day. It ended up being a 24/7 job for the first year, maybe year and a half. So, but anyway, we survived and everything is okay now. We eradicated polio too. So, yeah.
And right, and that's I wonder what you were leading up to 2011, which was the last case. I wonder what that was like. What you were hearing from the field and seeing as you were out. Also,
Well, we started. I mean, there's a pattern of monitoring the number of cases, and so we had, of course, these maps all over the place, and we would have them for the last 5 or so years, or even beyond that. And when we started to see the number of cases go down, so from let's say 2009, 10, 11, you see this trajectory going downwards. It's very encouraging, but we also remembered that had happened before in the mid 2000s where it started to go down, and then the next year it boomed back up again. So we weren't too excited about it at first. I mean, we were encouraged, but we were, I think, a bit guarded and wanted to make sure that we didn't outwardly or publicly express too much excitement because we didn't want to jinx it again. We had seen this downward trend before. So we did see the trend go down. And then, as you point out, 2011 came. And we were so discouraged when that first case came. And then over the course of the year, it continued to be just that one case in 2011. So that was tremendously exciting, but we were completely nervous. With just that one case, it's almost like the intensity and the pressure was even greater because we felt like we have just one case, we've made it through part of the year, and everyone in the world is watching. So all of a sudden, when you had a few cases and the numbers were up there, it almost felt like, okay, nobody's really watching because this is to be expected. But when it was just one case, it was almost as if everybody stopped looking somewhere else and they all turned to India. So we felt watched, and it was a very nerve-wracking year. And I remember every day coming in the office and going over to my technical colleague and saying, are there any new cases? And so this went on for a year, just every day wondering, was there going to be that new case or more cases? And we made it through the first year, 2011, and it was that one case. And then we made it through year 2. But those years after that one case were actually probably more intense than the years leading up to that. The work of getting down to that case, of course, I won't underestimate that. It was very intense, but it was almost as if once that last case happened, those years that came after that were really, we were on pins and needles, honestly, just waiting to see if it was true or if there was something that was going to happen. And it didn't, so we celebrated regional certification eventually.
which is huge.
Yeah.
It was a game changer for
Absolutely.
what came after that. I wonder if you come through your memory, what stands out to you in terms of lessons learned that could be helpful to future eradication efforts?
Mm-hmm. Well, I think in terms of future eradication or elimination or any global target, to me, again, just really seeking and nurturing a partnership that brings diverse skills to the mix. And I can't emphasize nurturing that partnership because I think that you have to be prepared to go the course. And it really is like a marriage with the partnership, and it will go on for decades, and you have to get through rough patches, and you have to reassess, and you have to sometimes pivot. But I think that you just have to be able to nurture and go the course with that partnership because you have to be able to address the unexpected and the unanticipated. So to me, really investing in that relationship with the partnership. And I think that when I think back to the 3 polio eradicators who started up polio and CDC, and that's Steve, Bob, and Roland, I think they really were such a critical piece of really nurturing and nurturing that partnership and really making sure that that they stayed connected and in a way that was constructive. So I think that we can't underestimate and undervalue really that aspect. I think that other lessons to me were that even at the country level or regional level or global level, to have a team around you and really, that's, I guess, a sort of partnership, but really having a team that is a team that you can really trust, if you will. So when I think back to India, I could not have done that job without really just an incredible team surrounding me to help guide and inform and disagree sometimes and add other perspectives. So certainly could not have worked in that context without really strong and really fantastic team members who I trust and who I continue to be friends with today, even years after leaving India. I think the other is just really ensuring that as you go through a very difficult or challenging initiative, and by definition, I think eradication, elimination, or global programs are challenging, is to make sure that you have a really strong communication approach, if you will. I know that over the years there have been challenges with ensuring to the donor community, for example, that their investment was well worth it, that yes, we were taking longer, but these were the reasons why. So really just ensuring that you have a strong communication component, whether that be to the donors, whether that be to the partnership, or whether that be to communities that you're working with. But just really, it's not just about the science. It's not just about having the vaccine or about having the lab, but you really have to make sure that that goes hand in hand with a very strong communication capacity at all levels. So community, partnership, ministry, international, and donor level. So to me, I think those come to mind immediately as sort of the top three lessons as I reflect on the last couple of decades.
I wanted to ask you about challenges in India.
Mm-hmm.
Challenges that you would hear about from the 1,200 staff
Mm-hmm.
people.
Mm-hmm.
What would you hear from the field?
Well, India's sometimes I think when we say India, most times people think of one country, but I sort of thought of it as 35 countries because at the time there were 35 states. I think it's increased now to 36, but each state was so vastly different and challenges would be different. So you could have some challenges in the South where you had certain states that were very well educated, and some of that information or education resulted in quite a lot of criticism or resistance to ongoing campaigns. So there would be challenges on that front. There would be challenges, perhaps different challenges in some of the western part of the country along the border, where it was huge, vast spaces of desert and lots of nomadic population. So the colleagues working there had slightly different challenges. Sometimes the challenges were with some of the government counterparts in some of the states. Some were amazingly supportive and very helpful. In some places, there might be government colleagues that were not as supportive, and so those were some challenges. I think of UP and Bihar as two states that were also incredibly challenged just because of hugely densely populated states, and some of the challenges of really trying to access millions and millions of people. Certainly different challenges for our colleagues that focused on urban areas like Mumbai or Delhi, which are so vastly variable in terms of populations. You could have large expanses of slums, but you could have parts of the city that were the incredibly well off and affluent, and everything in between, and how to manage that both AFP network as well as reaching children. So I think those were some of the challenges, but there were also programmatic challenges. There were just, challenges of trying to cover large areas. There were always, there's always going to be HR challenges too. Sometimes there were a number of issues that had to be addressed in terms of how we supervise or support staff and our understanding of that. So those were some of the challenges that we also tried to address. So I think when I think back, those were some of the greater ones that come to mind.
And how did you address some of them? Can you give a few examples?
So maybe one example is supervision and how we supervise. We, in each of the field offices, in each of the 275 field offices, you would have a medical officer in charge, and the medical officer might have 2 or 3 staff in that office. And medical officers come from a very specific training background. Physicians may not have supervision training or management training, and so may have a very unique management style. And so I found that sometimes that was a bit of a challenge, so a bit harsh or punitive. And so if that were detected in terms of maybe being a bit common, we might, in our regional review meetings, ensure that we had some component of supervisory training. So, in fact, one of the things that we rolled out in the first couple of years was a management training to all the medical officers, 350 or so medical officers. This was actually something that Bob and Steve Stewart and Melinda Mailhot had developed here in Atlanta. We were finding that globally, it wasn't necessarily the science that were the challenges, but it was really supervision and management at the field level. So we did roll out a management training to all the medical officers in India. Eventually, we also took all the senior leadership, the regional team leads, as well as the senior leadership in Delhi, and did sort of a senior leadership management and supervision training. In fact, Bob came in and helped support that as well. So that was, I think, one approach to a challenge that we detected. Another challenge was we had vehicles, for example, that were allocated to all the medical officers. And it was very difficult to monitor how vehicles were used, where they were going, if there was any sort of abuse of those privileges. So we actually rolled out a GPS system in all the vehicles, and we trained our person in Delhi that would monitor basically the use of vehicles to see if somebody was driving across the country and shouldn't be. One of the challenges was driving styles as well for all of our drivers. And, because our medical officers spend so much time in the vehicles, that was a concern. And so we recruited a vendor from Europe, and they rolled out a safe driving course, which again, we rolled out countrywide and trained all of our drivers, and it was a 3-day safe driving course. So, these are some of the challenges. And so when you pick up on or you observe that there might be a specific issue or challenge or risk, then it was typically something where we would just roll it out for all relevant staff.
Interested in how you pick up on some of these issues. Were they reported from the field? How did you become aware of them?
Well, there are different ways. You hear I was talking about the regional review meetings where we have all the medical officers come and we do a technical review and do an operational review in these 7 regions. We also had an admin assistance review meeting in each of the 7 regions, and we would bring all the assistants from the offices, but not their supervisors. And so we would have a 2 to 3 day exchange and interaction for all the operational components. And so that would be an opportunity to meet with field staff. You would also, you might pick up on complaints from medical officers about drivers being unsafe or being at risk or negative exchanges. And so you start to sort of put the pieces together and you realize that, oh, well, we probably need to do some kind of a standardized safe driver rollout. So, I mean, it's just sort of through different mechanisms, but it's really being in touch with staff and having a really, I think, credible and trustworthy staff in Delhi who really know how to sort of keep their finger on the pulse in terms of what's happening around the country. So through different ways, I think you sort of pick up on areas that need some addressing.
We're just at time, and I want to be respectful and let you
Okay.
make sure that we're out the door when you need to be. Are there any surveillance medical officers who come to mind as we're preparing for a second phase of interviewing potentially?
Okay.
So I was wondering if you could give some names of people that would be good to interview.
Okay. Well, the one person who comes to mind, because I've spent such a long time in India, and somebody who I admire greatly, and I'm thinking he's probably already on your list, is Sunil Bahel. Okay. So he's the person that comes to mind. And, when I think about Sunil, I often think in 2011 when Hamid moved to Geneva, it was Sunil and I. And so when I think of those last few years in the country office in India and certification, I kind of think of Sunil and I being in the foxhole together. But a huge amount of admiration for Sunil after Hamid left. So Sunil was Hamid's technical deputy, and I was Hamid's operational deputy. So we were the trio there in India. And so when Hamid left, Sunil and I huddled and made sure that we remained strong, and to this day, still very good friends with him. And I'm very pleased that he's actually gone on and been promoted to be the immunization coordinator for the entire region. It is now in CRO. So I think he is well placed because he has an amazing capacity. So I think that's one person that comes to mind for me. And I think that you're already talking with, Hamid, of course. Yeah.
What have we left out today? There's always a lot to cover, and if we're able to have a second interview, I was wondering what we should talk about.
Oh gosh, that's a hard question. I think nothing comes to mind now, but I think the one parting thought that I just want to make sure I do say is that despite it being such a challenging program over the years and decades, the amazing people that have been drawn to this really is, it's been such a gift to interact with amazing people who have been drawn to this. And I feel very lucky to have had that opportunity. And as difficult as some of the days and weeks, months, and years have been, I think the one thing that I'm always pleased to be able to say, regardless of what happens and, regardless of how difficult an event may have been, I always come out saying that it's always been a complete privilege to be part of the polio eradication efforts. So I'm really super enthusiastic, and I am absolutely optimistic that we're going to get this done, even if it's taken a bit longer and there have been many hiccups and bumps in the road. I feel that we have the right people, and I feel like we have the commitment to really get this job done. So I'm looking forward to perhaps the next series of interviews once we actually have reached global certification, and we can talk more then.
Is there anything you wanted to say about the legacy of polio?
Hannah?
Sure.
Okay, go ahead.
Okay. What is the legacy of polio eradication to you?
Well, the ultimate legacy is a disease that's gone forever and will never be on the planet to infect any other child. So, I mean, that's an amazing legacy when you think about how many children and people have been negatively impacted, even just 10 or 15 years ago. So being polio-free is the ultimate legacy, absolutely. And in terms of just the wealth of lessons learned, which I think we're starting to grapple with, I think because we've been so immersed in trying to get the job done, we probably haven't spent as much time on lessons learned as I think we will be able to once we actually get through these last 3 endemic countries. So the wealth of knowledge that has come that I think will benefit future eradication and elimination programs is also a tremendous legacy. Absolutely.
Any other final thoughts?
I look forward to the interview when we reach global certification.
Great. Me too. Thank you so much.
No, thanks for the opportunity.
Appreciate your time.